Start off with Dr. Thompson. Dr. Thompson helped put this together by reaching out to Dr. McMasters and Dr. Lee, and has kindly agreed to introduce them. And then, Jimmy, after you've done that, I'd like to take just a minute to introduce the other folks that are on the call before Dr. McMasters and Dr. Lee get started, so they kind of know who's listening in.
Sure, glad to. Yeah, it's my pleasure to introduce two of my friends and colleagues, longtime colleagues. These two have been the real backbone of the Virginia chapter of ASAM for 10, 12 plus years. And they're good friends. Both have had a big influence on me. Starting with Dr. McMasters, this is Dr. Mary McMasters, who's a distinguished fellow of the American Society of Addiction Medicine. She, like me, trained originally in internal medicine and was boarded in hospice and palliative care as well, and sort of found her way into addiction treatment long before I was even aware of the field, because she was one of the few who was willing to take care of these vulnerable and needy patients, especially in the western part of the state. Mary's been involved with VASAM and multiple statewide addiction-related issues, has become really well known as an educator in addiction medicine, always teaches our Addiction 101 course every year, both at the VASAM conference and elsewhere. She's been appointed to different councils and advisory committees by Governor McAuliffe, Governor Northam, and announced recently that she's really retiring soon, but gratefully, thankfully, she's been willing to come and do this for us today. And Dr. Lee, Jonathan Lee, is triple boarded in medicine, psychiatry, and addiction medicine. And I think Johnny just got his MBA from William and Mary. So another highly educated guy. Johnny has been the medical director at the Farley Center for a long time, 12 years, maybe, Johnny, or more. And was, I can hardly believe this, but the past president of VASAM just before myself. It's hard to believe that I followed in the Jonathan Lee, because I admire him quite a lot. Also a well-published and greatly admired addiction medicine physician and psychiatrist. And so really glad to have them both here, great leaders, thinkers, and physicians to teach us about contingency management, which will be fascinating for everybody and for me as well. And I guess turn it over to you. Back to you, Tony, to introduce a few others.
Thank you. Yes, I don't want to take up a lot of the speaker's time, so I'll move quickly. Our board members, Dr. Thompson, who just spoke. Tim Spencer is the city attorney for Roanoke City. Daryl Washington is executive director for the Fairfax Falls Church Community Services Board. And Craig Markfa is assistant secretary of Health and Human Resources under the Youngkin administration. He's representing Secretary Littell, who wasn't able to join us this afternoon. The other folks on the call include Dr. Jerry Mueller, who's the director of the Wright Center from VCU. He's going to be speaking in the next half of the presentation today. And then members of my team here in the OAA office, in the order that I see them on my screen, Kara Mozan, Cindy Newman, Adam Rosatelli, Charlie Lindicum, and Matt Terrell. So with that, I think Dr. Lee is up first. And Dr. Lee, take it away.
Oh, yeah, thank you, Tony and Dr. Thompson, everybody, for being part of this meeting. So I'm going to share the PowerPoint. And in fact, it's going to be Dr. McMasters who kicks it off. So let me make sure this works, and then I'll get the PowerPoint teed up for her. See, can you all see the PowerPoint?
Yeah. Yep.
Okay. And then I'm going to put it onto the slideshow. All right. It's ready for Mary.
Okay. So Dr. Lee and I were asked to talk about contingency management. From what we've heard, the Opioid Abatement Authority is being asked to give some money to these programs, and you wanted to know what it was and how, more importantly, how it fits within the context of addiction treatment. Next slide. Johnny. Johnny? Yeah, okay. So you can't fix any problem if you don't define it. And I'm sure as all of you have dealt with the public, people will come to you and talk about addiction, but they're not talking about the same thing. So I want to start with the definition. Addiction is a chronic relapsing brain disease. The subjective symptom of addiction are cravings, and that's what the medicines target when we have medicines available. It's also what the counseling and the other brain reprogramming does. The objective symptom that we deal with is poor functioning, and poor functioning is not only on the level of the individual who may not be able to hold a job, who may have a really bad family life, lost custody of their kids, but also it is affecting our entire society. It affects our GDP, it affects our readiness, our armed forces. We have a high level of kids in foster care. So as a society, we are not functioning as well as we could because we have a lot of people with active disease of addiction. Two things you need to know about addiction in particular. Addiction is not substance specific. Sarah Tomashow, Melton Tomashow, and I were driving around the state of Virginia 25 years ago, trying to talk prescribers into prescribing opioids more in a safer manner. And we told people then that if you throttled back on the opioids, you're going to have another problem, probably methamphetamine. And here we are. So I'll get down off my soapbox, but please remember that addiction is not substance specific. The other thing that's important to understand is that addiction is not the same thing as physical dependence and withdrawal. I drink a lot of coffee, and if I don't get my cup of coffee in the morning, I get a headache. That's physical withdrawal. That's physical dependence. That is not the same thing as the disease of addiction. We often have to deal with physical dependence and withdrawal in conjunction with dealing with the disease of addiction, but just withdrawing people doesn't work. If anything, it sets them up for dying. Next slide. So I want you to, I'm talking about terminology because the terminology around addiction is very confusing. It's confusing for those of us in healthcare. It's confusing, very confusing for patients in the public. If you hang on to the definition of addiction as a chronic relapsing brain disease, you can hang the other terminology systems onto it. Next. The first system of terminology is from psychiatry. It's the DSM-5 manual. The word addiction is not in this manual. They talk about opioid use disorder, stimulant use disorder. Basically, it's the same thing as addiction in people who prefer opiates, people who prefer stimulants, people who prefer alcohol. Next slide. The next system of terminology is the American Society of Addiction Medicine, and we certainly do use the word addiction. And what's important about ASAM is ASAM has the ASAM criteria. That's how we triage people with the disease of addiction. That's how we figure out how likely they are to die and how high a level of care that they need to be safe. Next slide. The next terminology system is the ICD-11 codes. And what I like about these is they include a lot of codes for the side effects from substance misuse. They include a code for opioid-induced depression, methamphetamine-induced psychosis. We have a big problem with people getting the wrong diagnoses. People get diagnosed as major depression when really it's opioid-induced depression. People get not diagnosed as having bipolar affective disorder when indeed they have methamphetamine-induced psychosis. Wrong diagnosis, wrong treatment, bad outcomes. So it's important to get the right diagnoses. The point here is that there's a lot of different terminology. I have to toggle between all three of these for just one patient encounter. And but if you understand the basics about what addiction is, it all makes sense and it'll be easier for you to talk to your constituents. Next slide. Of course, we always have pejorative language for when people don't have other words to use. Next slide. So the ASAM criteria provides the appropriate level of care. Not everybody needs to be inpatient. And it's a lot like the level of care for other chronic diseases like diabetes. For most people with diabetes, the vast majority, you teach them how to check their blood sugar, you show them how to watch their diet, and they don't need any more interventions. It's the same for addiction. Most people with addiction realize they have a problem. They trot off to a community support group in a church basement, and they do just fine. But there are people with diabetes who need more intervention. They may need to be supervised by a dietitian. sometimes they wind up as an inpatient because they are really sick with ketoacidosis. Same thing with addiction. The sicker you are, the higher your risk is of dying, the more intervention you need. It needs to be personalized. Please understand that being on medication does not dictate the level of care. There are people with diabetes who have a perfect diet, perfect weight, they exercise, but they still need an insulin pump. There are people with the disease of addiction who are not using any substances, including the legal ones, including cigarettes and alcohol, who completed their counseling, who are very invested in their community support groups, who still need buprenorphine and methadone. Next slide, please. So the ACAM criteria applies to the disease of addiction in general, but ACAM also puts out clinical practice guidelines on different substances. And they just put out a new one on stimulant use disorder. Unfortunately, we don't have any medications to decrease cravings for people with the disease of addiction who prefer stimulants. But we have found that contingency management is very effective in dealing with these patients. By the way, this guideline is very useful and very accessible for everybody. I've put the link there. It's not very long, but it's got great information if you would like to access it. Now, Dr. Lee is going to drill down some more on contingency management. Okay, Johnny.
Hello, thank you. So just unmuted myself, although for some reason I can't see the PowerPoint anymore. Let me go back to it really quick. Can you all still see the PowerPoint right now? Oh, here it is. Okay, so just as a addendum to what Dr. McMaster has already presented on, so this, as far as contingency management and its utilization, so I'm actually part of the Continuing Professional Development Committee for the American Academy of Addiction Psychiatry. So that's the OAA. So they have a performance improvement practice guideline that's actually going to be coming out this year for practitioners to look at. So Dr. McMasters is correct that there are currently no FDA-approved medications that's been approved specifically for treating the disease of stimulant use disorder. So that could be whether it be methamphetamines, other stimulants as well. However, there is clinical research data to show that there are some medications that can help to potentially decrease the use of stimulants as well as decrease cravings. So some of those medications are actually part of the PIP or the PIP. So effectively, these are medicines that could be used even if they're not FDA approved, so they'd be off-label use. So I won't be talking about them in this particular presentation, but I just wanted at least to add on that there's a lot of research going into treating stimulant use disorders as well as other, substance use disorders for addiction. So, and if at any time anybody has questions or need me to stop, just let me know. So for contingency management, this came out related to the National Drug Control Strategy, is that, sorry, there's going to be a train that's going to be going right by the Farley Center. So if you guys have trouble hearing, let me know. So, so the thought is to improve treatment quality and also to include payment reform, that contingency management could be utilized with motivational incentives, tangible rewards to reinforce positive behaviors because it takes time to make change. And this could be not only for stimulants, as we mentioned earlier, but also for opioids, and to motivate and sustain not only treatment adherence, sometimes called compliance, but adherence would be the other word, so that they can continue to be in good recovery or remain abstinent from substances. So these incentives are effectively an integral part of any sort of protocol-driven, evidence-based contingency management program. And that's one of the things that for us as clinicians, but also for the OAA, that have to look carefully at these different proposals out there. And one option, not to say this is the only one, is that a lot of smart technology applications can help to monitor, provide some accountability related to smart debit card technology. It's not the only way to do it, but this is something that's been published by the National Drug Control Policy. So as far as the basics of what contingency management includes, so it's based on rewards. It provides whether it be external motivation as well as eventually internal motivation to kind of drive the person to stay accountable based on operant conditional conditioning as well as behavioral economics. And the goals are effectively pretty basic. It's concrete, it's attainable. These are SMART goals that can allow somebody to remain hopefully motivated to stay in good recovery based on things that they should be doing for their recovery, but also attaining effectively either benchmark goals, rewards for doing that. In fact, a lot of the apps that we use these days utilize that as a way to motivate us, such as taking so many steps, getting a little a goal on our smartphones or smartwatches when we do something that's healthy for us. So this potentially for some of the patients who are just early in recovery, newly sober from substances, provide some additional motivation that might sidestep this feeling of hopelessness, where they feel like, just feels like things aren't quite worth it. Just recently today, met with a patient who recently got sober from alcohol and still having symptoms of depression, but also that sense of hopelessness. So, trying to find that balance of like, how do we provide help for this person? So, it can also subtly and subconsciously establish priorities for recovery by one, rewarding critical recovery behaviors. So kind of either based on the program or let's say the application, it kind of prioritizes certain things and can increase the reward based on kind of what they're doing or, provide little rewards or little gains over time. And it's kind of based on a schedule. And sometimes if there is a setback, or let's say if there was a urine drug screen that detected something that is either unexpected or effectively shows that they use the substance, then that might lead to a change in the reward system. It might be kind of effectively changing whether it be privileges or the points that they have to utilize. So in order for contingency management best practice for it to work is that it needs to be used frequently. And we're talking about not just once a week, but ideally more than once a day even, so that somebody's actively utilizing an app or some sort of system that keeps them engaged throughout the entire day on a daily basis. And again, going back to SMART goals, this is something that's attainable, that's achievable, that's measurable. So one example would be measuring, are they showing up for the therapy sessions? Are they showing up for support, mutual support group meetings, whether that be Alcoholics Anonymous, Narcotics Anonymous, or other mutual support groups? Making it on time and getting their urine drug screens, breathalyzers done, effectively getting a reward for having a negative drug screen. And again, drug screens are as good as, the person who provides the urine that's hopefully theirs, as well as either observed or not observed, and the technology or toxicology as far as how to confirm the results. But let's say if this is a valid urine drug screen with a negative result, then they potentially might get a reward for that. And then other things such as seeing that they're filling their medications on time, quote, taking their medications as prescribed, whether that be doing pill checks, looking at their bottles, or showing up for their appointments. Let's say if they're getting like an extended release medication to prevent use of a drug or substance, they can verify that they're getting the medicines administered. So the system should be designed to prevent gaming of the system, which we'll address a little bit later on, controversies of contingency management. So one of the things with patients with addiction is that they don't do very well with delayed gratification. So typically these rewards have to be pretty immediate. So let's say just like if today I worked out and I kind of got like did a personal best based on time, or let's say something that I lifted, then it's nice to see like a little ribbon. And that ribbon could be effectively just an electronic reward. It doesn't have to be necessarily a physical reward, but could be something that just provides some form of a, satisfaction to say that they've achieved something. And a lot of times these little markers are helpful to show that they're making progress, and then they get to see what's actually happening. So they could be tangible based on what they see on whether it be an app-based system, but also could be something that they actually see based on monetary sort of a system. So monetary rewards are typically utilized in a way that allows it to be contained in a system, whether that be these are small, less expensive, but could be utilized specifically for certain things, such as, let's say, paying bills, utilities, things like that. That would be ideal. So they almost might end up being like a voucher, kind of depending on, the system that contingency management is utilized. And typically that person, a lot of the treatment these days, we look at what's valuable, what's important to that person. So it doesn't necessarily mean it has to be a lot of money, but it could be just something that's important to the person. And so that could be person specific as to that contingency management reward. But also it could be based on, again, these sort of, the system as far as rewards or progress over time, and trying to kind of achieve long-term recovery and sobriety. So again, some of the challenges, we'll talk about more. Some of the cool things about contingency management is that it's been well researched. There's been more than 100 randomized controlled trials out there looking at this as an approach for the treatment of substance use disorders. It's been shown to be effective, can be cost effective. However, kind of depending on who you talk to, it's could be utilized more. It's something that we could use in many different treatment settings, whether that be residential, outpatient, inpatient, et cetera. So just to give you some data, so these bar graphs effectively shows that if you were to have a control group versus a incentives group, which is where they're utilizing some form of contingency management. And some of these studies could be either over a 4-week period of time and then measuring abstinence over a 12-week period of time. So just kind of, you can look at the bottom parts to look at the details. But effectively, one thing with drug abstinence is that it's not uncommon for people to pick up use of a substance even when they're actively in treatment. So for the control group, 9% is relatively low rate of drug abstinence in this particular group, whereas those in the incentives groups were in the 24% range, which is definitely in this particular study, significant difference in a population of patients who are effectively identified as cocaine, methamphetamine use disorder patients. And then looking at drinks per month, this is in a control group versus incentives groups. For alcohol use disordered patients. And they measure this based on whether it be breathalyzer tests, as well as, I think in this case, breathalyzer tests specifically. So they could earn, looks like about $219 on average based on this pilot study that occurred. And it looked like there was definitely decreased use of alcohol in the incentives group. So based on this particular pilot study. And then in the third one, which sometimes we forget about, how tobacco use disorder, particularly the smokable form, is one of the biggest preventable public health diseases that we can treat. So as far as encouraging people to quit smoking, the quit rates increased by 3 times based on this particular study looking at a control group versus incentives groups. And they were measuring nicotine based on their study. So there definitely is the positive effects of contingency management in different settings. And people might worry about, oh, is this very specific to just certain patients? Is it generalizable? And based on these other settings and studies, we see that contingency management could be applied to dual diagnoses patients, which sometimes now we call co-occurring disorder patients, whether that be patients with substance use disorders co-occurring with, let's say, major depressive disorder, bipolar disorder, schizophrenia, other disorders. People experiencing homelessness, there's also been positive results using contingency management. People in the criminal justice system based on days of abstinence. Patients who are pregnant, in this sample, looking at patients who have opiate use disorders, adolescents, young adults based on smoking abstinence, and also patients with stimulant-associated cardiomyopathy, which not only there's that stimulant addiction, but then there's that cardiac component, which we know that patients who develop heart disease have a high incidence of unfortunately developing heart attack, death, things of that sort, which again, high cost for managing cardiomyopathy as well as stimulant addiction together. So it shows that 78% of staff reported that contingency management might have been moderately to extremely useful in this particular study in 2023. So as far as cost benefit, this is again an overview based on the return on the investment. So greater than $30 in societal benefits for every dollar invested. So ROI is positive in year 1. This is based on the Washington State Institute for Public Policy published in 2021. So that first one is looking at contingency management for smoking cessation for pregnant women, which again, that's a very important population to take care of. Particularly not only taking care of the person, the woman, but also the pregnancy as well. And then incentives, high level CB, and compared to cognitive behavioral therapy, compared to motivational interviewing, which these all have different, values as far as efficacy for treating these different problems. So these are, again, a sampling, and then you get to take a look at medications as well that's used for treating addiction, whether that be methadone or buprenorphine, more specifically for opiate use disorder. So the thought is that the costs at full value evidence-based model in 2013 could be kind of in that $100 per month range, but that doesn't have to be exact. That's just a ballpark from that one study. And it's thought that duration at minimum should be at least in a 6-month period with rewards, and it could be contingency management with community reinforcement approaches, seems to have a better long-term effect. And on-site manual management, that's where the providers are partnering with the people who are managing the contingency management, whether that be educating the person who's in treatment, in recovery, but also the staff as well, providing supervision, learning about skills and patient recruitment, of course, and tracking them appropriately. So patients have to be able to access this thing, whether it be an app. I know that not everybody's going to have access to smart devices, but this could be done in various forms. And I know that certain patients, even ones with CMS, Medicaid, Medicare, sometimes do have access to smartphones as well. And of course, the challenges include, like, how do people randomize a sort of reward / contingency system as well as drug testing? And that's something that typically gets worked out with the system to find out the cost benefit ratio. Problematics as far as data entry, because that can be a lot of data for people who, they're kind of track over time, like who's actually going to be paying attention to this, unless there's like an algorithm that effectively provides the reward, and then somebody who, stays accountable as to how the rewards are being utilized. So the US DHHS OIG also provided some sanctions against fraud, waste, and abuse. And I believe there'll be a slide after this. So programs throughout the United States that have utilized a smartphone app system, just because that's one way to deliver contingency management, includes Brightview Healthcare, which is that's in an outpatient setting, oftentimes for opiate use disorders, but also other substance use disorders as well. There's also Alcoholics Anonymous oriented programs, such as in Massachusetts. There's been nationwide telehealth case management, as well as employee assistance programs that utilize contingency management for their employees. Gavin Foundation related to criminal justice reentry, as well as nationally renowned AA models for certain inpatient 28-day programs for treatment. Research has been done in various academic centers, including Baylor, Berkeley, Columbia, Johns Hopkins, MIT, MUSC in South Carolina, Charleston, NIDA, National Institute of Drug Abuse Addiction, and other programs as well, University of Vermont. And then commercial insurers, we know that nationally, regionally, and state by state have been adopting contingency management, and Medicaid in certain states have been utilizing it as well as certain state, whether it be state opioid response grants. So these are the states that we know at the time that it was presented previously, actually by the American Society of Addiction Medicine. There was Dr. David Gasfried, as well as Dr. Wesley Clark, provided these slides for us to share. So the OIG did provide some guardrails for a checklist, and this is, again, referencing, like, how do we prevent fraud? So for contingency management to work, we need to make sure that whatever they're utilizing is research validated, evidence-based practices, that there's a formal written protocol that they're following. Rewards should not exceed $200 per month per patient, which kind of gets back to that other ballpark value of about $100 per month. And then document a clinical diagnosis, a care plan from a licensed professional clinician. In this case, I would argue addiction medicine provider, if possible, to be part of this as well. Individualized care plans that document behavioral targets, amounts, and schedules. So again, a way to track the system. And then full accounting of every payment, its purpose, the expectations and patient's efforts. For example, specifically recording appointments expected that are attended or not, and then each substance test expected and the results. So I think in this case, having somebody who knows how to interpret the studies, that being, whether that be toxicology, urine drug testing, understanding the nuances of that is quite important, because sometimes there could be false positives, false negatives, as well as other unexpected results. So the gift incentives and their distribution must be accurately inventoried and audit ready. That means for the Office of the Inspector General. And then protections against recruitment, rebates, refunds, or kickback offers, to, let's say, the providers or the treatment team, I suppose. So I believe the next slide, I'll be handing it off soon to Dr. McMaster. So again, this is just an overview of funding that's been provided to contingency management programs, whether it be commercial insurers, employers, EAPs, federal block grants, state legislation, including governor's initiatives, alcohol tax monies, state, county, Medicaid, and Medicaid MCO vendors, CMS 1115 waiver, the state opiate response grants, as I mentioned earlier, as well as opiate manufacturers, distributors, settlements, which I know some of that's related to what the Opiate Abatement Authority is looking at right now. So I'm going to hand it off to Dr. McMasters.
Okay, so only 2 more slides here. These are some controversies that I've heard about contingency management and paying for it. The first is the objection that we're paying people not to use drugs. And yeah, that's true. But part of this is you have to understand is that when addiction activates in the brain, brains don't work very well. It damages the brain. Also, stimulants are extremely neurotoxic. So we need to retrain these brains. And if we have to kind of use positive incentives to do it, that's not a bad thing. It's also harm reduction. You know, I wish that every diabetic patient I saw would come back to my office in a month and have lost 50 pounds and be running marathons and have a perfect diet. But the fact is we have to meet people where they're at. Another objection I've heard is that people are diverting the rewards. Yes, that happens. But usually it happens when these are taken out of context of the complete treatment picture, where people are being enabled versus being treated. It's important to pay attention not just to the compliance that Dr. Lee went over, the negative urine drug screen, showing up for counseling, but we also have to look at the bigger picture of functioning. Are these people going back to work? Are they regaining custody of their kids? That better functioning is what we're looking for. Another objection I have heard that is that we're substituting one bad behavior for another. Some people see pulling that little thing out of the fishbowl as gambling. Yep, but this also sounds a lot like the objections we had to buprenorphine. And by the way, pharmacologically, buprenorphine is not substituting one opiate for another. We don't have time to get into that. But that argument doesn't work for buprenorphine, and it doesn't work for contingency management either. Next slide. The bottom line is that we are looking for better functioning, not only in the individuals, but also in the community. This is a paper that was in the Journal of the Canadian Family Physician. It was done in 2015. It was for a very insular First Nations community that is north of Ottawa. So very isolated, but not so isolated that the opioids weren't getting into this community and causing a huge amount of trouble. So they totally embraced the complete treatment program, buprenorphine, but more importantly, community support groups, counseling, promoting recovery. And by doing this, they had a decrease in criminal charges of 61%, child protection cases by 58%, increased school attendance by 33%. They even had an increase in revenues in the local general store. Now, once again, this is probably not generalizable to American communities that are not quite so insular. But, you know, if you could go back to the governor with these kind of improvements in functioning, you get a medal, or shoot, you could probably be elected governor. But the point is that what we are looking for, and what you should be looking for as you consider these grant applications, is assessing the overall improvement in functioning. You should see improved functioning. anyway, next slide is we have a lot of references, and the final slide is just acknowledging some people who helped us with this. And that's it.
Well, thank you both very much. I know that was a lot of information. We asked you to cover it in a compressed time frame. For members of the board and for the staff, again, the reason that we asked for this presentation is because a board, the OAA board, we think is going to be presented with some proposals that would include or maybe even focus on contingency management. And so as a policy decision, the board will be in a position, I think soon, to need to make a decision on whether the OAA will support contingency management as an evidence-based practice and not just whether or not it's eligible for funding, but whether it's competitive for funding. And that's certainly a decision that the board will have to make in its judgment. And we wanted you to have some of this background before you were put in a position of needing to make that type of decision. And so at this time, I'd like to turn it over to any of the members of the board who are on the call that might have any questions for Dr. McMasters and Dr. Lee.
No questions, but I would like to thank everyone for the presentation. Really did appreciate this presentation. And quite frankly, Tony, would love to see this type of, from my perspective, I'm a lawyer. A lot of these issues are new to me. I know that we're working with our local judges on a navigator program to help keep people in programs such as this so that we can reduce the number of children that are removed from families as a result of opioid addiction. But this type of thing helps educate me, and I believe puts me in a better position where I'm more capable of ascertaining what where our money should go and making a good choice and being a good steward for the revenues that we do receive from these lawsuits. So, yep, the lawyer talked too long. I apologize.
No.
Here's a question, Johnny and Mary, that just might be of interest to the other board members. And that's just, I mean, a lot of the evidence you presented, especially Johnny, didn't distinguish, it showed efficacy with multiple different drug classes. One of the things we sometimes have to think about on the OAA is that the funding is specifically targeted for using in opioid use disorder. And so I wondered if you would talk a little bit about contingency management's efficacy according to drug class, whether there's evidence that it's effective across the board, one class more than another. Any comments about that?
Did you want to go first, Dr. McMasters?
No, go ahead, Johnny.
Okay. I'm unfortunately I don't have all the research studies out there pulled up. But I suppose if we look at that contingency management slide, the evidence, I can share that slide again with everybody. That does break it down a little bit. Again, it's kind of like population by population. I'm not going to be comprehensive, nor do I really have the knowledge to really be able to answer this question very well. But I think that's a good question, Dr. Thompson, is that, can you all see this slide now? So I think one of the areas, which earlier there was that, question about, how does contingency management apply to the criminal justice system? So again, this is evidence that it can be helpful in this setting. And I think that even though the special population of patients with pregnancy, which we take a very hard look at, they also have opiate use disorders as well. So in this particular sample of people in 2001, it was thought that contingency management could be helpful in the special population pregnant patients who had effectively less opiate positive samples or more opiate negative samples, however you want to look at that. So that is reassuring. As far as comparing it, I would say, like, as one category of substance to another, I just don't know 100%. I think that becomes complicated because many of our, well, maybe it's like in my settings where residential treatment setting program is that many of our patients are using more than one substance. So it's often
Always, yeah.
yeah, alcohol with other substances, opioid stimulants, so often polypharmacy or polysubstance, although, the nomenclature depends on who you talk to. So I guess if, as far as focusing on just one substance alone might not be potentially the right way to do it from a contingency management point of view. And I kind of getting back to Dr. McMaster's is that looking at substance use disorders / addiction, addictive disorders, whatever you want to call it these days, as a whole, is that it's more than just one substance. It could have been that the tip of the iceberg is that we identified opiate use disorder, but they may have other use disorders or they may have co-occurring disorders along with that. So I think that based on some of the evidence that we've reviewed and presented is that contingency management could be applicable to managing the disease of addiction. It doesn't necessarily have to be, one substance at a time, if that makes sense.
It's never one substance. It's always polypharmacy.
Yeah, I think what you presented already, especially that evidence you cite, Johnny, it makes it clear that it works in opiate use disorder. And there's been a lot of talk about contingency management around stimulant use disorder, but I think that's especially because there's so few other options with stimulant use disorder other than contingency management, but clearly it works in both. As a matter of fact, one of the first viable commercial products that ever existed that were where insurance funds could be used to support the use of contingency management was a program from a company called Pear Therapeutics. It was called Reset, that was widely used for about a year. It was approved, FDA approved for treatment of opioid use disorder in particular. And there was a second product for substance use disorder in general. And both were proven to be effective. The issue why this product didn't thrive as a commercially available product, although it was really popular, was just, again, the funding question.
Mm-hmm.
So it's
yes. Yeah, it's good that you brought that up, Dr. Thompson. So I actually spoke to the CEO of a company. I won't say the name because I think they've actually applied for a grant related to contingency management. So effectively, that CEO, their company took over Reset. So it's now been rebranded and utilized as a smartphone app or as an app for opiate use disorder as well. So
Did that answer your question, Mr. Spencer? It appears that contingency management is effective for substances other than stimulants.
yeah.
Well, folks, great discussion, and I don't mean to cut it off, but I want to make sure we leave some time for Dr. Muller to talk about a very exciting project that he and his team are working on with the OAA, and that is to develop basically a technical assistance toolkit for Virginia's cities and counties. And so just briefly to introduce Dr. Muller, he is the director of the Wright Center for Clinical and Translational Research at Virginia Commonwealth University, and is the Associate Vice President for Clinical Research at VCU's Institute of Drug and Alcohol Studies. He has quite a pedigree at VCU. He's been a professor. He's been a division chair of addiction psychiatry and holds a number of qualifications. He's well known in the industry. I think probably all of the clinical folks on the call know Dr. Muller, and we're extremely pleased to have him as a partner with the OAA working to build this toolkit. And with that as a very brief intro, I hope that's okay, Jerry. I'll turn it over to you.
Sure, no, that's fine. It just is just to make a comment about the contingency management. So we've done several different clinical trials with contingency management in addition to medication, going back a long ways. And I'm an old guy, so we make back quite a few years, and it is effective. And it actually, we did a study showing it combining with medication actually improved the effect of the medication, so that it can be used with medication, not just by itself. So the toolkit is a collaboration between the Opioid Abatement Authority, VCU, the Wright Center in VCU, and ASAM. And so the overall purpose of it was to provide cities and counties with access to information about evidence-based practices they could use for their opioid abatement funding. And we would do this through an online portal, but on top of that, outreach, community outreach and engagement and consultation. And so the portal is sort of the way in to access it, but as already is happening beyond the portal, cities and counties are reaching out to us directly to ask us to help with what kind of evidence-based practices they can use. Like, for instance, Henrico County and several counties have reached out to us about how treatment for services for a needs assessment for services for pregnant and parenting women with opioid use disorder. So this is sort of the gateway into the access to supporting that. And it exists online right now, and I can show you, it's not done yet. But I can show you, if I can share my screen, I can show you what the online portal actually looks like. But can somebody let
Garrett,
me?
can you make Dr. Muller a co-host?
Okay, give me 1 second.
Okay. So can you see my screen?
Yes.
So this is the website, and you can see the actual web address is virginiaopioidtoolkit.org. So it's online currently. And like I say, it's in process. Some of the images I'm not super, like, it's kind of cool, but I was like, what does this image have to do with opioids? So but it's in process. So this gives you an overview of what the purpose is: to guide cities and counties on evidence-based practice for prevention and treatment. And it's based on 9 strategies that were developed by Hopkins. And there's a link to this primer on spending for opioid litigation. And the 9 strategies include, broaden access to naloxone. I was trying to make that bigger. Oops. So broaden access to naloxone, increase medication for opioid use disorder, provide treatment support for pregnancy and postpartum period, improve treatment in jails and prisons, funding warm handoff programs, recovery services, neonatal opioid withdrawal absence syndrome, enrich prevention strategies, expand harm reduction programs, and then data collection and research. And so each one of these little links has a section for learning more on them. And so, like, expanding access to naloxone, if you want to hit the learn more, it gives you a lot more information about that. It's like about Revive training, and then additional education materials across the web, and then more local resources. And then finally, this is where the collaboration with other sites is going to be important. So when you get down to see what others have done, this is a place that's going to be expanding over time. And that the goal would be to show what other cities and counties within Virginia have done, so that they can say, okay, I'm in Chesterfield. What has Arlington done? And maybe I can use the same kind of methods, because they are similar county, and I'm from Texas originally, so my knowledge of the exact details of all the cities and counties is not as good as it could be. But that would provide local evidence, and we could even, and we're planning to do even more details as far as specific evidence-based providers and practices that can be put down into this category down here. And built into this as well is and the website is in progress. So what we want to do currently, the website, if you go there, requires you to sign up. I want to change that so that we get you have access to the information, but then we encourage you to sign up for detail because we want information, because we want to know who you are and ask how we can help specifically. So we can keep track of who's using the website, what are the specific needs of the individuals and the individual cities and counties. And then they can link up to it with asking more specific questions about it. And eventually, the other piece of it that we will link to this is, so we have data using the All Payers Claim database about if you want to know more about what's happening and what resources are specifically available in your city and county, we can provide that to you at the zip code level. Like exactly what does the overdose epidemic look like in your zip code? What does what kind of population is it happening in? What's the demographic of the population? The number of providers prescribing buprenorphine in your area. So all of those kinds of things we're able to access with the All Payers Claim database, and we can share that with the cities and counties. And then the final thing is we're participating in a number of outreach programs that are happening with the Opioid Abatement Authority. So we're going out we went to one in Charlottesville. There are several coming up where we're meeting with the cities and counties and officials to face-to-face get information from them and share information to them about the website and the toolkit. So that's where we are. It's a work in progress, but it is moving along. And so with that, I will open up to questions about that.
And if I can just add a comment, that in places like Fairfax, you basically have a behavioral health authority that's part of the county government. But that is the exception in Virginia, not the rule. Across the Commonwealth, most community service boards are semi-independent from the cities and counties that they serve. The actual cities and counties have their role in the opioid crisis has been more on the response side. So sending a police officer, sending an ambulance, locking someone up. And so now that the cities and counties have funds for opioid abatement efforts, it's not something that they've traditionally been directly involved with, unless, such as with Fairfax, it's part of the county government. And so we get a lot of questions from communities across Virginia about basically, we don't know where to start. Like, can you point us in the right direction? And what we found is that there is no toolkit like this available anywhere in the country. And so Virginia, I think, has the opportunity to really kind of lead the nation. And that's why the board approved the grant with VCU to build out this toolkit. And then VCU can't provide all of its services, customized services to cities and counties on the OAA contract, but cities and counties are prepared to work directly with VCU to pay for the assistance that they're receiving. And so I think it benefits all of the parties involved, and I really appreciate the effort that Jerry personally, as well as his team, has put into this. And the next phase is going to be populating this website with data, and that's not something that we expect VCU to do by themselves. So as members of the board, the staff encounter things that need to be in the toolkit, we're going to be asking for your help in submitting things. And then Dr. Muller's team will review the submissions before allowing them to be posted into the toolkit. So again, fantastic program. We're really excited about it. And any members of the board have questions for Dr. Muller? Anyone else on the call that maybe isn't a member of the board that has any comments or questions?
No, Tony, no real question. I'm looking forward to passing all this information along and also hopefully get some other people to watch this. It's only an hour presentation and get all this, get more people familiar with it. But I'm very excited to see what Dr. Mueller is doing and finding more about this. But contingency management, I've been texting some people over at the state Medicaid agency to find out if they've looked at any of this and have they ever considered any of this. So excellent. I really appreciate this effort this afternoon.
Well, Craig, those texts might stir up a hornet's nest, but that's sometimes what we need to do.
That's okay. I can stir up a hornet's nest with a text and I'm doing my job. That's fine.
Well, folks, it's a miracle to cover this much technical information in just under 1 hour. I appreciate everyone carving out the time and at the end of the day. Hopefully it's the end of the day for you and you're able to go home after this, but thank you again to our presenters. And we will be making the recording available to the full board and we'll post it on our website. And so with that, thank you very much and have a great evening.
Good evening. Thank
Bye.
you.